welcome, my Be Health Empowered family, to another episode of Excuse Me, Doctor. My name is Dr. Melissa Clark. Please call me Dr. Mel. I'm delighted to be back here with you, just as we are each and every Monday, to make sure that you, the listening audience, has all the information that you need to make wise health decisions, not just for yourself, but for your family and for your community. So if you are new, like brand new, and never been here before, welcome. Please remember to hit that like button if you're checking us out on Facebook, subscribe if you're checking us out on YouTube. And for those of you who have been here before, you know that we cannot do this unless we have our amazing co-host, Miss Lila Mays, coming in hot from the West Coast, Mr. Wayne Bruce hot from the East Coast. We're meeting in the middle. How y'all doing?
Hey, coming in hot compared to the rest of y'all, for sure.
Woo,
in terms of weather.
Okay,
tag team back again.
About to rub it in.
Yeah, I was trying to overlook that, Dr. Mel. I was trying to overlook the fact that whole thing about her being warm and us being cold. I was trying to overlook.
I mean, we cold. We in LA, we are cold, but it's all relative.
It's all relative. It's minus 20 on the East Coast, or at least feels like it. So I'm just saying.
With minus 20. It is minus 20. And I'm trying to,
Yeah, I'm no weatherman. I'm a doctor, but I mean, it is cold.
I play a weatherman on TV sometimes.
Well, regardless, I hope everybody is keeping safe, not going out on the roads unless you have to. You got your ice melt, all that stuff. And that, you're not overdoing it with the shoveling, and that you are keeping safe if you don't have to walk on the ice. So all of that.
Yes. Stay safe, y'all. Stay safe. Yep. What we got going on tonight, Dr. Mel? It's a new year.
Mm-hmm.
It's not coincidental. We're talking about bringing new life together. You know what I mean?
Exactly.
It's not a coincidence.
It is not. It is not. Happy New Year, by the way.
I know. Happy New Year. I don't think it's too late. I don't think it's too late to say it. Happy New Year, everybody.
Happy New Year, everybody.
I'm going to say it like they say it back home. Happy New Year's.
Yes,
all of them.
With the S.
Yeah, all of them.
You got to have the whole thing. Happy New Year's.
And throughout the whole year.
Right.
Right. So, all right. So in talking about bringing new life, right, we're talking about pregnancy today, and not just the 9 months, everyone, because a healthy pregnancy starts way before that.
You are so right. It starts years earlier with access to care, with managing any chronic conditions that you have, or even knowing that you have them, right? And doctors actually listening to you and working with you on maximizing your health even before you get pregnant.
Exactly. And what we mainly hear about are the complications that Black women have where it's hard to be heard. We aren't talking enough about what needs to happen even before the start. Make sure our moms and babies come out healthy and strong. That's what we need to be talking about.
Yeah, it's like showing up at a race, late to a race, and you didn't even know you were supposed to be training for it.
Exactly.
Exactly. So we have an amazing guest today, Dr. Donna Neale. She's a renowned OB-GYN. She focuses on exactly this topic, what we're talking about today, how to make sure that, you're healthy before your pregnancy. If you have chronic conditions, what you need to be doing, everything from PCOS, and we're going to understand what that means, to fibroids, to chronic stress, and on down the line. So make sure that you keep it locked here, because she is going to come out the gate with just dropping knowledge.
Indeed. And it's important to note that prevention only works when care is accessible and trusted. And with everything we've seen about Black maternal mortality, that trust has definitely been shaken.
Most definitely.
Yeah. So today we're going to shift the conversation. from blame during pregnancy to preparation before it, because healthy babies start with healthy women and men.
All right, healthy women and men. That's right. And healthy women need early care, real support, and community.
So make sure that you stop what you're doing right now. Share this episode with everybody who is in your circle, who you know needs to have this information, because it's going to be a great show.
It's going to be a great show. And it's very poignant because over the holidays, just recently, as last week, I became a great uncle. I'm kind of digging that.
We need some of that noise.
I mean, where's the
congratulations? Congratulations. There we go.
Shout out to my niece. I don't want to say her name. I don't want to get her all out there on the interwebs and everything. You know how it is. You know how the interwebs be. But shout out to my niece. She knows who this is.
Shout out.
Shout out to my sister. You send this to my niece and tell her we shouted her out on the show.
Right.
We can't say. Right? So, we got to go to the week that was in health and wellness.
Yep, and we got a lot to talk about here too. So what do we have up first?
All right. So up first is LPA, Women in Heart Health. Dr. Mel, I don't even know how to tee this one up, because what is LPA? Is that some kind of throwback album? Like, do I need to be concerned about it since the focus is on women's health here?
Yes. Well, Lp(a) stands for lipoprotein A. It's a kind of cholesterol, and it's especially good at clogging your arteries. What makes it different than what you might hear about regular cholesterol panels and lipids and all that stuff that you get checked when you go to the doctor is Lp(a) is genetic. You can't diet or exercise it away. And if it runs in your family, more than likely you may inherit it. So it's an important thing to know about.
I literally have never heard of it. What does our BHE family, especially the ladies, need to know about this?
So there was a recent study where researchers followed about 28,000 healthy women over a 30-year period of time, and they found a clear pattern. Once their Lp(a) levels hit about 30 to 60 milligrams per deciliter, their heart risk started to climb. Women with really high levels had about a 74% higher chance of having a major heart episode, especially heart attacks.
Oh, wow. So Black women have heart disease more often, right?
Yes, that's a critical point, Lila. Lp(a) levels tend to be higher in Black individuals, so both men and women. And Black women already face higher disease risk due to stress, structural inequalities, delays in diagnosis. So that means Black women, or some Black women, have a hidden genetic risk, even if they're doing everything right, exercising, eating right, etc., if they have this marker for Lp(a).
Okay, so should everyone get tested?
So if you have a strong family history of early heart disease in your family that's sort of unexplained, you should talk to your doctor about testing. So there's no current medications that lower Lp(a), but if it's high, you can work on all the other risk factors that you can impact. So your weight, your blood pressure, your other cholesterol markers, quit smoking, and move at least 150 minutes per week. All these things are really important in terms of containing your risk for a heart event, especially a heart attack.
So I just, to be clear, Dr. Mel, is this something that we're already being tested for? Is it something we should be asking?
This is something you have to ask your doctor for. And especially if you have a history of heart disease in your family, especially if it's at a young age, those are compelling reasons to get tested.
Okay, great. Good to know. Good information. All right, moving on. What should I eat? Dietary guideline confusement. So, Dr. Mel, have you heard about the new food pyramid the government just unveiled? It's totally flipped from the previous ones. Everything's flipped from the previous.
Everything is flipped, and this is no different. Meat and full fat dairy is now at the top of the food pyramid, which means it's what you should eat the most of. And it pushed grains and even fruit down to the bottom.
But don't most nutritionists say eat more plants and fewer fatty meats?
Exactly. So that's why nutrition experts are like, what's going on? These new guidelines are quote unquote muddled and contradictory. On one hand, they tell Americans to eat more meat and full fat dairy, while on the other hand, they're still recommending that saturated fat should be no more than 10% of your calories, right? So those are two like totally different messages. Because meat and dairy are the biggest source of saturated fat. So that's like saying eat giant donuts, but don't get too much sugar.
So yeah, I mean, it's really ridiculously confusing. And I read that the recommended serving for fruits and veggies it's actually lower than in previous guidelines, even though people are supposed to eat more of them.
Right. Exactly. You know, we see studies that show 7 daily servings of fruits and vegetables are actually protective of your heart and your blood vessel health. So fewer heart attacks, fewer cancers, fewer strokes, etc. So pushing meat and saturated fat and overemphasizing protein at the expense of fruits and vegetables can, in the long term, be detrimental.
So what's good about these new guidelines?
Well, the one good thing is they do emphasize avoiding ultra processed foods. So that's, you know, your hot flaming Cheetos, your sugary cereals, your chips, your other ready to eat junk food. So even though that makes sense, it's kind of buried in all this other confusement, right?
Yeah.
So just remember, avoid the ultra processed foods, but also eat more plant-based foods, foods with fiber, foods that are whole foods, so ones that don't come with a label, right? That you have to read. And that's really what you should be emphasizing. That's what all the studies show.
Okay. All right.
Basically, my doctor would have a problem with that pyramid. I have a new cardiologist. She gonna have a problem with the pyramid, man.
Yes, she is.
Use wisdom, though. We got to use wisdom.
Exactly.
You jumping in,
Dr. Mel, banning kids. Let me get in on this one. Banning kids from socials.
I was gonna say it's not banning kids; it's banning
kids from socials. The down under way. I mean, come on, did you see? I mean, what happened in Australia? They banned kids under 16 from the Clock app and Insta. Gone. So you heard of Insta, now it's Insta gone.
Well, they want to protect their children's mental health and reduce exposure to cyberbullying, grooming, and all the harmful content that comes as a side effect of being on social media. But it kind of got me to thinking, like, what if we did that in the US? You think how would that go over?
Wait, are you saying we should start booting kids off their phones?
Well, here's the thing. Not every child has the same access or safety online, right? Children in under-resourced communities often face more online predators, fewer protective tools. So parental control isn't just about setting limits. It can also protect children who are especially vulnerable. So you know, I think what the Australians did is basically level the playing field by putting these restrictions in place for everybody.
So it's not just no more memes. It's protecting kids who might be at higher risk because where they live or go to school.
Right. And research shows kids exposed to constant social media stress can have higher anxiety levels, higher depression, body image issues, especially girls and especially Black and brown teens.
Hey, man.
Yeah, we need to ban it for adults too.
I'm curious.
While we're at it.
Hey, look, put it in the chat, man. I'm curious to know what y'all think. Did Australia go too far, or have they gone far enough? Or have we not? We just said, forget it. We're not going to go that far. What about the teens that can handle it? let us know what you think in the chat.
Yeah, I'm curious to know. I'm curious for people to weigh in on this one.
Come on now.
Because, we know that they're already banning, certain schools are taking away kids' phones during the school day because they're finding that it leads to better academic performance and less depression.
Yeah.
Duh. So yeah, I think it's something to consider. And I want to make sure that we have enough time for our guests. So I'm going to suggest that we just go straight into our next segment, and we're going to see y'all back in just a little bit because we need to get to the reason why we are here tonight. When we talk about pregnancy, and we've talked about Black maternal health on the show quite a bit, but one of the things that we haven't really focused on is that a healthy pregnancy starts long before a positive pregnancy test. Managing your health conditions, reducing stress, all these things are really important. But it also means you have to have access to care that you trust, and a support system that has your back. So with Black women having pregnancy complications at unacceptable rates, we're turning to Dr. Donna Neale, who's going to talk preconception health, pregnancy, and getting the best prenatal care. Dr. Neale is an OB-GYN. She's associate professor of maternal fetal medicine at the University of Maryland School of Medicine. She's an obstetrical champion for the health strategy and engagement. She's a medical director of NEST, and we're going to ask her what that is. And we're just happy that she's here tonight with us. Hey, Dr. Neale.
Hi, Dr. Mel. Thank you for having me on the show. Thank you for having this conversation because I think it's super important. Like you said, I think many of your listeners have heard the statistics that, Black and brown women die 3 times more likely than our non-Hispanic white colleagues, even when we control for education attainment, income attainment, neighborhoods where they live. We still don't do as well as our cohorts. And another statistic I always like patients to hear, not to focus on, but to hear, is that our daughters are more likely to die in childbirth than our grandmothers. And that shouldn't be, and because we have progressed in so many other ways from resource. But I'm here because I'm a glass half full girl, and I want women to be able to embark on a pregnancy, that journey, with enthusiasm, with hope, with excitement. And so I'm really here to talk about a new, framework, how we think about pregnancy, particularly in the Black and brown community. Lila was saying, what'd you say?
I'm here for it. And that is a strong way to open up. I want to level set, though. I want you to tell everybody a little bit about your practice, what you do, and what NEST is.
Okay. All right, great. So I am, like Dr. Mel said, I'm an OB-GYN. I am a specialist in maternal fetal medicine. So I specialize in high-risk pregnancies from either the maternal perspective or the fetal perspective. So if you have high blood pressure, if you have diabetes, if you unfortunately lost a pregnancy in a prior pregnancy, your baby has something structurally wrong with them. The baby has a chromosomal problem. Those are all the things I would take care of. You have twins, you have triplets. If you are above the age of 35, any kind of condition that could potentially complicate pregnancy, I would take care of you, and I'm happily, wanting to take care of you.
Great. And what is NEST?
What is NEST? So NEST is an acronym. So for ladies who have not had children and those who have already had children, you'll remember that when you're in labor, right now, the best way we have to monitor the fetal heart rate to have a sense of how well the fetus is doing throughout the labor process is through some monitors ladies wear on their belly. And these monitors are looking at the contractions and also looking at the fetal heart rate. Well, NEST it's an acronym that stands for Neonatal Outcomes Enhanced by Escalation, a Shared Mental Model, and Telemetry. So what it is that we're able, across the whole University of Maryland health system, we're able to monitor all those fetal heart tracings to give the bedside team and, have an additional pair of eyes watching with the bedside team. So essentially, if you deliver at a University of Maryland hospital, not only do you have your bedside team watching, but you also have a remote team member also watching with the bedside team, and we all work collaboratively together. And the goal is really to optimize, the labor journey in terms of making sure the fetus is tolerating that, because we want to give every baby in our state the best chance, the best chance to start it off.
That's wonderful. And you're the medical director for that program. So it's sort of like an extra set of eyes. Well, I know that you sort of already kind of told us some of the statistics around Black women and pregnancy outcomes. What makes pregnancy uniquely stressful for Black women in this country?
Excellent question. And I'm going to say that it is multifactorial, meaning there are lots of things that lead into it. But I'm here to hopefully take away some of those things that can contribute to it. It's all kind of, I'm going to list some. It won't be all inclusive, but I want to try to hit the top. So I think one of the top things that makes pregnancy stressful is that most people know the statistics now. Most people are fearful that they're going to be the one that's not going to do well during their pregnancy, number one. Number two, I think a lot of women are not necessarily in a relationship with their doctor. And when I say relationship, I think Lila touched on it earlier in your show, that you've got to have a trusting relationship with your provider. And having a trusting relationship also speaks to having access to, good providers. Again, I'm a specialist. Perhaps in your community, you don't have access to a specialist like myself. And that can make women weary to think about, are they going to be able to take care of all of me? Because we all present with, I have this thought about every patient's different. And we really want to provide what we call precision medicine. I want to take care of the patient who's in front of me, not necessarily a caricature of a patient or a statistic of a patient, but the patient that's really in front of me. So having the opportunity to find a provider like that, I think, is a reason why ladies worry and get stressful. The other thing is many of us don't have support members. We don't have a partner who's maybe living nearby. We don't have a partner. We may be separated from our family. So I think that can be very stressful to think, and maybe even if you're in a relationship, you may still feel stressed, like I'm going to be by myself. So those are some, and then I guess the fourth thing is that many of our Black and brown women enter pregnancy with some underlying medical condition. And you worry, like, how is this going to impact my pregnancy? Or you're taking medicines, how is this going to impact my pregnancy? And again, I'm here to say that, yes, we can have a condition and we can still have a healthy pregnancy.
Yes. What part of the stresses that you mentioned come from the healthcare system itself, right? So you mentioned like not having access to a trusting relationship with a physician. How much, though, do we as physicians potentially contribute to that in terms of maybe not hearing and what women, especially a Black woman, might be saying is going on with them?
Yeah, I think that's a great question. And I think to make change, we all have to own our part, right? The physicians, the healthcare system as a system has to own their part. The physician has to own their part. The patient has to own their part. So from a health system perspective, I think a couple of things play into that. We know that there's this thing called implicit bias, where providers, bring their past experience when they're dealing with their patient, not really, again, looking at the patient that's in front of them. Hospital systems are working on that from the perspective of having mandatory training around that. But I always say you didn't build Rome in a day, right? You didn't develop this bias in a day. So it can't be a one-off training. So I think the medical system can really play their part in terms of requiring this to be ongoing training. Just like we have ongoing training from pretty much any certification we have doing medicine, we have ongoing training around that. I think we have to think also from the healthcare perspective, from the systems perspective, is how much time are we giving our physicians to take care of their patients? So whether you're Black, brown, red, yellow, whatever color, the doctors are we're up against time. Like I have the luxury a little bit because I'm a specialist, so I'm given a little bit more time because patients tend to be a bit more complicated. But many of my colleagues who practice general obstetrics and gynecology or internal medicine, they're seeing patients every 10 minutes, 15 minutes. And that honestly is just not enough time.
Just to be clear, because they work for a health system as opposed to having their own practice. Right.
Correct. And I think, the days of the, solo practitioner, those have gone by the wayside for various reasons. So when we think about, the responsibility of the healthcare system, we need to, patients are complicated. Patients are bringing a lot of issues to their visits, not just medical issues. There are a lot of social drivers of health. There are a lot, there are lots, not just the traditional, when we think of health, many of our patients think of health, but there's a lot of mental illness across the board and just in our society. We would be remiss if we didn't talk about some of the effects of the post-COVID era that, patients bring with them. So there are lots of things that patients are bringing with them to their visit. And I feel, we want to, ask our healthcare system, like, give us the time to see these patients, see our patients.
Now
then from a patient perspective, go ahead.
Well, I was just going to say, you mentioned social determinants of health. And I know we've talked about that on the program before as being those health related issues like, your job status, your transportation, your housing, your food, whether you have access to food, your access to the healthcare system, neighborhood environments, domestic violence. I mean, there's so many things that actually impact on you, and sort of like part of the way that they impact you is because they cause higher rates of stress in your life. So talk a little bit for me about, does chronic stress affect pregnancy at the physical level, at the biological level? And if so, how?
So a simple answer would be absolutely. And
Okay.
then to really delve into the weeds a little bit more, I want to make one clarification. I really try to say social drivers of health because, patients often, we give our patients so much to own. And a lot of times patients find themselves in situations where they have these social drivers, which are not by their choice. So I try to stay away from social determinants of health as versus social drivers of health, just for our
Good
listeners,
point.
listeners. And then when we think about some of these determinants or drivers of health, I want to go on answer that question two different directions. One, we know when patients don't have enough to eat, when patients are not housed, when patients are unfortunately victims of domestic violence, those things can lead to adverse pregnancy outcomes such as poor fetal growth, can lead to premature labor from various mechanisms, and we don't necessarily have to go into that. So we definitely know there's some adverse pregnancy outcomes that can be related there. The other thing to think about, and this is more on a scientific, but I think it's really important for our listeners to hear, because again, we want to take the blame away from our patients, is that what we know stress does, this, in medicine and in the human body, it causes something called weathering, which also leads to what we call epigenetic changes. So we all are made up the same from a genetic perspective. And how we walk, the kind of the slings and arrows that hit us as we walk through our journey of life can change our DNA in little ways that ultimately can lead to chronic illness. And so we have really good data and other, not just in obstetrics, but just in terms of in science, to show the impact of weathering and epigenetics. And it's a field that really hasn't been explored much in obstetrics, but it's coming. So I just wanted people to know about that.
Right. And I think that whole idea of weathering, if you think of something being left out in the elements, it sort of wears it down. That's one of the reasons why it's thought that Black women have sometimes worse pregnancy outcomes, because as a Black woman, all things being equal, we are exposed to more stress due to racism, discrimination, stigma, bias, etc., even if everything else is equal, right? So
absolutely.
Yeah. So,
and that's why I think it's really important for listeners to recognize that, it's not just an access issue. It's not just, kind of your insurer payer issue. It's not just because you had high blood pressure, because like I was saying at the onset of the show, you and I, we were both physicians, which means we had to go to college, we had to go to medical school. We're gainfully employed. Our outcomes are worse than our colleagues, our non-Black and brown colleagues. And why is that?
Exactly. So that kind of leads us back to the beginning. What do you want women of childbearing age to know about their health before they get pregnant, and how that relates to a healthy pregnancy?
So again, I want to start with this framework of how we should think about pregnancy. So I advocate our patients to think about pregnancy is that pregnancy is a stress test for life. Like how you do during pregnancy often dictates how you're going to do for life. So with anything, how you prepare, like if you had a test and they said, if you do 100% on this test, you're going to do great in life. Well, you would study for the test, right? So I want to back it up and say, hey, let's make each patient the best that she can be when she enters the pregnancy. So that if anything, your listeners leave today, I hope they leave with this compelling thought that I want to be the best I can be before I enter the pregnancy, whatever that means, whether that means I'm controlling a chronic medical illness, whether it means I wanted to lose some weight, whether it means I need to be on a different medication, whether it means I need to heal from a past experience, whatever it means. I want your listeners to hear this compellingly, that we want every patient to be the best they can be.
I love that. Why do you think so many women aren't told that before they get pregnant? Like, I mean,
I have been thinking about this.
I would even say as a physician, I had never thought about that, up until maybe recently.
I've been thinking about it a lot because this is it's a passionate space for me, like to really from a patient education, perspective. And to be honest, I don't know. I have some thoughts about it. And one of them is that, probably 20 years ago, the field of obstetrics was probably more male majority. Now that has shifted, I think it's probably more female majority now. So I think some of our thoughts about pregnancy, have really evolved in terms of, what happens to a woman's body during the pregnancy, what that lends her to and leads her to after the pregnancy. And so again, that pushes us back to before, because it's not so recent that we've found that women who have like gestational diabetes are more at risk for diabetes once they finish the pregnancy.
Later in life,
later in life, high blood, like preeclampsia or high blood pressure, they're more at risk for cardiovascular disease. So that's kind of made us think in the field, that's back to try to prevent some of these complications of pregnancy. So to answer your question, I really don't know, but I'm hopeful that it's because now there are more female women in obstetrics and gynecology, and we go through it. We go through the process.
Right. Now, I hear that there is a lot of chat on social media about PCOS. What is PCOS? How does it affect pregnancy? And if you could also put it in context of something that we might know about before we get pregnant that needs to be addressed.
Awesome. Yeah. So there's been a lot of information about PCOS. I think probably because of the GLP-1 medications are out on the market now. So PCOS, that is an acronym
for those people who don't know, GLP-1s are the things like Ozempic and Mounjaro, Wegovy, right?
Yeah. So PCOS, sorry about that, listeners. So PCOS is an acronym for polycystic ovarian syndrome. It used to be called polycystic ovarian disease, but really we know it's more of a syndrome. And how it impacts women particularly is that we have ovaries, and these ovaries become cystic. And what it does, it can cause ladies not to have their menstrual cycle. So then that can lead them down the path of what is perceived to be infertility or the need for IVF. It also alters how we metabolize our glucose. Some women become what we call insulin resistant. So they present in a picture very much like diabetes. So that can have implications during the pregnancy too. It can cause, because also it interferes with this overall metabolism, it often will lead to obesity, where ladies are really trying everything to lose weight and it's not being helpful. And again, where there was Ozempic and Wegovy, it interferes with that insulin, that insulin pathway. So that's where these drugs can be very beneficial for women. So it can cause irregular cycles or no cycles. So that can lead to infertility. It can cause, again, diabetes-like picture. So you have some of the risks associated with diabetes. And it can cause obesity outside of pregnancy. And that in itself can lend itself to complications from the pregnancies. I would say those would be the three top kind of ways that PCOS has implications during a pregnancy.
Is there anything that women who are diagnosed with PCOS can do to prepare for a healthier pregnancy before conception?
Absolutely. So now that we understand this is a syndrome so much more than we did, say, 20 years ago, there's if ladies are thinking, maybe this is what's going on with me, I would say definitely check in with your obstetrician, gynecologist. If you don't have one that you particularly trust, your internist, and even an endocrinologist, because there are people who really specialize in this syndrome. And depending on what your manifestation is of the syndrome, there are medicines that we can use before pregnancy that are actually safe during pregnancy to continue if you need them. So there's definitely help to be had if you think this is something that you may be experiencing.
Great. I also want to transition to another condition that's more frequent in African-American women and can impact your ability to get pregnant and have a healthy pregnancy. And those are uterine fibroids. So tell me why they're more common in Black women and why does it matter in pregnancy?
So we honestly don't know why they're more common in Black women. We honestly do not know whether there's something about so fibroids, for our listeners, are a benign collection of cells of the uterus, and they can be as small as a pea or they can be as large as a basketball. So it really varies, and they are more common in Black and brown women. We do not honestly understand the mechanism of that. There is a genetic component in some cases, so that then of course it runs in families. And the issue is that it can impact pregnancy on various ways. One, it can block, the opportunity for the egg and sperm to get together. So it can cause, again, lead to this sense of infertility, although it can be treated. We'll talk about that. There are ways to be treated. During a pregnancy, they can block for the pregnancy to implant, or the pregnancy implants in a place it should not be, the placenta implants in a place it should not be. And all of these things can cause complications during the pregnancy. They can grow so big that it tricks the uterus in thinking that you're further along in the pregnancy, and can lead to early delivery, and sometimes so early where the baby can't survive. Often can cause a lot of hemorrhage, especially large fibroids. Sometimes they can be so large, or they can block the birth canal that the baby cannot turn around, and ladies are more at risk for cesarean section in the setting of uterine fibroids. So uterine fibroids can certainly cause havoc. And I think in the past where patients thought, well, that's just normal. Like, my periods are super heavy. I've always had that. My aunt had it. My mom had it. My sister had it. We think it's normal. I would say pause and really seek out, again, your obstetrician gynecologist and say, hey, I want to know, is this from fibroids? Because again, there's treatments that we can offer ladies before pregnancy to help optimize their pregnancy outcome. And this really their lifelong health, because with heavy bleeding often leads ladies to a severe anemia, and that can have implications too.
That is really valuable to know. I also wanted to make sure that we hit on, what do you want women to know about how they can be empowered in managing conditions like high blood pressure and diabetes with their doctors?
Great question, because I'm a really big advocate of, the patient taking ownership of their own health. And there are a couple of quick things I think that are pretty easy to do, and I think most patients would feel comfortable, because I know that there is this relationship. Can be this hierarchy relationship where patients often don't want to question their provider, but I think it's important there's a way to do it that's really, I think, really accessible and comfortable for the provider. So that's the first thing, is that if you have any condition and you're thinking about getting pregnant, be honest with your provider. Say, I want to be pregnant. I think sometimes patients feel like, oh, I know I probably shouldn't be pregnant with this condition, so I'm not going to let anybody know, and I'm just going to show up pregnant and they'll deal with it. But we could deal with it a lot better if that condition was controlled before. And it's important because there's some medications that we used outside of pregnancy to control an underlying medical condition that we don't use during pregnancy, but we have other medicines that can, be just as effective. So that's why it's important to have the conversation. I'm a big advocate of always bringing somebody with you to the doctors. Whoever you want, your partner, your bestie, your mom, your auntie, whoever it is, because for two reasons. One, sometimes we need some, like right, to make us feel confident that we can have this conversation. I recognize that as a provider, and I try to settle my patients and really welcome them. But I understand there can be that hierarchy relationship, number one. But number two, we can't hear everything. We know, studies show us that patients hear about 10% of what we tell them. So I'm a big advocate to have
only 10%. So there's a whole 90% that is crucial. That
correct.
Just normally you just don't. It might be too much information to process at one time. Yeah.
So your bestie, so your buddy, I call it your sidekick. Bring your sidekick along, someone that you trust. And they will have them take notes. They don't necessarily have to engage in the conversation, just have them take notes. And then you guys can go back and review, and then you can have another conversation. One of the nice things, I think, there was so much death and despair with COVID, but there's some good things that came out of it. And I think one of those things is that we've gotten much more in depth with telemedicine visits now. So there's much more opportunity to follow up with your provider. You have that first in-person, go back with your bestie, go over your notes and say, you know what, request, I'd like to meet with you, virtual visit. There are a couple questions I had about our conversation. So first is let someone know you want to be pregnant. It's okay. Say, I want to be pregnant. And two, bring your bestie to listen to whatever the doctor has to say about that, and then follow back up, because we know you only heard 10%.
Right. Now, along the lines of being empowered, what should women look for in an OB-GYN even before they get pregnant that's going to make them feel more confident if they do get pregnant, that they'll have a great partner, medical partner in that?
That's another great question. So I'm a big advocate of that. So a couple quick key things. One, I think if someone doesn't want to see you because you're not pregnant, probably not the doctor you want to see, because you do want to have an opportunity to have what we call preconceptual counseling. That's what we're talking about really here. And, you know, a physician who's not interested in that model of care might not be the physician you want to have on your care team, because things come up. You always want to be able to have discussions. And again, I'm a glass half full girl, and I'm also I'm a proactive person. Like, I want to be prepared before it happens. So if you can't have a conversation about your preconceptual health, probably not a good choice. If you have found a doctor who says, yes, I'd like you to come in, and they are not looking at you in the eye, they are standing up, they're on the computer, probably not a good person for you. Because as we talked early in the show, we know that physicians are only getting so much time. You want that time to be dedicated to you. You know, you're the patient, you have needs, you have questions. So those are some quick, 4 quick things that I feel like, you know, like you can get a sense. And I guess the fifth is listen to your own self. I mean, as women, we have this intuition, you know, inner voice, however you describe it for yourself. And I think sometimes we minimalize that. And I think it's very important that we don't minimalize that during pregnancy, because lots of things come up and some things don't fit the textbook. Some things are hard to describe. And you just want to have somebody you can say, you know, I don't feel right, or something doesn't feel right. I can't describe it. And so you want to make sure you have that type of relationship, or you have the opportunity to have that type of relationship with your provider. It takes time, obviously. You know, you don't develop a relationship in 1 10-minute visit, but you'll get some cues of, you know, how this might fit for you. And it's okay if you meet somebody and you're like, you know, it doesn't really fit good, doesn't feel good, like the Progressive commercial, not gonna fit. It's okay.
Right. I liken it to speed dating. You're not gonna, you know, go out with the first person that you talk to, right? So continue to look until you find that fit. I can't believe it's time to bring in the audience, but I definitely want to get the audience in so that they can get their questions in. Lila, Wayne, would love for y'all to come back. Tell us what you're seeing in the chat. Tell us if people are putting in comments, concerns, anything on those lines.
All kinds of comments. So hang on here. Let me pull this. Pamela C. Chapman says, great idea to have your buddy come with you. I think that's awesome. Lots of comments about our recap. But there's and here's a question regarding the recap. I'm gonna come back with the question for Dr. Neale, but one of the questions is, where is it? From Ivani Smith. And Dr. MEL, this is for you. Where did it go? It was about, what causes more inflammation, meat or plant-based?
Interesting question. I think definitely because of the saturated fat and animal fat in meat, that's going to be more likely to cause inflammation than a plant-based diet, which is one of the reasons that plant-based diets are emphasized in terms of health and health and better health overall. Again, it doesn't mean that you have to be a vegetarian. It just means that you want to front load and maximize the amount of plants. Like the main event on the plate shouldn't be the meat. It should be the plants.
Okay. And for Dr. Neale, how does chronic stress affect pregnancy at a biological level?
Thank you for that question, Lila, and the listener reader. So as we talked about a little bit earlier, like there is this sense of this weathering effect. And so what weathering effect actually does is causes little breaks within your DNA that can then ultimately set you up for some of the chronic medical conditions. And it's a hard area to study, but we know it happens in animal models. We know what happens in other like medical conditions, not necessarily pregnancy, but where we think about it in pregnancy is like, why is it, like I keep going back to it, why is it with Dr. MEL and my colleagues, my non-Hispanic white colleague, why do they have a better outcome than me? I've done exactly the same thing. I went to the same schools. I live next door to them. My income attainment is the same. We see the same doctor. We go to the same hospital. Why? What is it? What is it? So that's what made people start thinking about, like, what is the impact of weathering or we call epigenetics on pregnancy outcomes. And we know, again, in terms of just, if you take away that weathering epigenetics model, we know just what stress in itself does. So stress causes a release of cortisol. And interestingly, cortisol release, you need release of cortisol to start labor. So it's good to have some release of cortisol at 40 weeks of pregnancy. It's not good to have release of cortisol at 24 weeks of pregnancy. That's too early.
Right.
So we see women who are in situations where they're, again, some of these social drivers of health, such as being unhoused, victim of domestic violence, unfed, these cause, that makes all of us anxious and stressful. And we do see increased rates of preterm labor and preterm delivery in those settings. So there's twofold, for the listener person who asked the question, there's really there's two mechanisms of that. One, stress in itself can cause some release of proteins, hormones that normally start labor. Then it's like a fight or flight. So if it's so anxious, if something bad is going on, we need to move on. We got to get out of here. We got to have this baby, right? So that's kind of like from an evolutionary perspective. And then from the science perspective is really what is happening at the DNA level, which is an open field. So if there are any budding scientists on the line, we got a lot of work to do.
Okay.
And I would also just want to throw in there, the examples you gave of stressful situations are really important. But what about just like the cumulative stress of everyday life? The boss at work, the argument with your spouse, traffic, bills, that you're wondering about ends meet. Those things add up too, right?
Correct. And we think we all can manage some, right? But because in addition to the things you just outlined, Dr. Mel, we also have these things called microaggressions. So as you walk through the world, people are throwing little things at you. You can't really put your finger on it, but it wasn't something nice they said to you or something nice they did for you or did to you. And those are what we call microaggressions, and they weather us. So in addition to the stress of like the traffic, so we're fully housed, we're fully fed, we're fully insured, but we still got traffic, we still have weather, we may have to pick up a child from childcare, somebody in the family's sick. We all have those things. But in addition, many Black and brown people walk around, all of us at some point have these things called microaggressions, where things are being kind of done to us that we can't describe. It's hard to let other people know what's happening, but it's happening. You know it when you see it and you feel it.
Yep.
And those are things that weather us. And those are the things, again, from an evolutionary perspective, it says, oh, this is not a good environment. I need to do something about this. And so your body will, kind of release some of these hormones and proteins, and some of those are not good for pregnancy. Some of them are not good for your health. You guys were glad to show off by heart health. Many of these things we asked, why do Black and brown people have more heart disease? It's not all genetics. That's LPA is a genetic perspective, but not all of it is genetics.
Right.
Absolutely. And there are things that we can do to manage our stress on a day-to-day basis, like meditation, yoga, walking, exercise, therapy. So I like you said, you're a gal cup half full, right? Want to make sure that everybody knows that it's not a non-fixable situation.
Well, and you're not alone. I think the other thing is you're not alone. Sorry, Larry.
Right.
No, but Dr. Neale, that leads right into my next question, which is, how can partners and families truly support a pregnant woman's health?
How you going to take my question? I'm the partner. How you going to sit up there and take my question?
Well, one of the first things I say, it's really, again, really easy. And like when your partner is going to the doctors, ask them, what did the doctor say? And if they have no idea what the doctor said, you say you're not blaming them. Just like, I'm going with you next time. Because there had to be some kind of exchange of some type. Even if everything's great, there should have been some type of exchange. And if your partner can't say what that was, then you want to go. So you want to support and say, you know what, I'm going to go. If you have a partner who is pregnant and you see them indulging on some non-healthy behavior, it's just like, hey, wait a minute, and those non-healthy behaviors could be they're burning the candle at both ends. It doesn't necessarily mean they're smoking or drinking. It can be like, hey, they're getting 4 hours of sleep. That's not sustainable. You see them, grab, the potato chips as opposed to grabbing the fruits and vegetables. So those are things that are not sustainable. So I think calling people out, like being a part of the team, is another really easy thing to do. And of course, a back rub, feet rub, tell them to take a nap when, they have the opportunity. It's always helpful.
Well, I mean, Dr. Neale, Lila truly just stole my question. I texted her earlier that I was going to ask that question, and she stole it from me. I'm kind of embarrassed here, but I think the partner also has to hold themselves accountable in the situation to make sure that they are part of the pregnancy. I mean, from the start, from conception on, you really got to hold yourself accountable to your mate or to your partner about the pregnancy before you can hold them accountable for what they do. Hold yourself accountable. And I would also say be a role model, so if you got bad eating habits, if you like hot links and stuff like that, you're gonna have to give up the hot links.
Okay, hot links is
that.
a running joke on the show.
Hot links is an inside joke, Dr. Neale.
Oh, okay. Well, I love it though. I love it, and I want to actually make it even more granular, because this is when you bring up a really great point. One of the things is like smoking, right? So if your partner is pregnant but you're a smoker, you don't want to be smoking around them. We know that secondhand smoke can lead to mostly things once the baby's born, but you want to have, start, being that role model, start modeling that good behavior. So that's a big one we see a lot with smoking, drinking, where, before you're pregnant, you're hanging out, but now partner's pregnant, help them. Don't engage in those same type of behaviors that may not be safe for the pregnancy.
And also too, I would say, try to remove yourself as a source of stress to your partner as much as you can. That's part of the accountability. Sometimes it might be better just to go into the other room rather than to have it out and, cause additional stressors to that individual. Amen. So just be supportive as possible.
Amen.
Yeah.
Don't be mean to the pregnant ladies. Don't argue with the pregnant ladies. I have a really important question for Dr. Neale. What are some warning signs in pregnancies that are commonly overlooked in Black patients?
Great question. So one of the real common one is because our skin can be a little bit darker. Often we are not able to see when we have rashes that can happen during pregnancy. Any kind of skin eruption, people don't see them. And so that's really important. If you have any kind of irritation in your skin, please bring it to attention to your doctor. And then generic ones, things that are happening more commonly. So we know preeclampsia, the high blood pressure in pregnancy, happens more commonly in Black and brown women. And some of the symptoms can be very vague and can go along with pregnancy. So a bad headache, swelling can be very common in pregnancy. But if you're getting swelling up to your knees, not just your ankles, not to your feet, but it's coming up to your knees, you've got shortness of breath, you have blurred vision or spots in front of your eyes. So more than just a headache. So you have a headache. A lot of people have headaches. You take a Tylenol, it doesn't go away. And you have these other symptoms. Like I said, blurred vision, spots in front of your eyes, swelling up to your knees, shortness of breath, pain underneath the right breast area. All of those sometimes can be signs of your blood pressure rising. And so you want to bring that to attention of your provider.
So that's great. That's great. We're in the speed round now. Everything is we need your quickest answers, your best answers. We have a question from Sharon Irby Randall. Says, can you wear a patch or gum to stop smoking while pregnant?
Ideally, no, but I said ideally. So, you never get something for nothing. So that's why we try to minimize the different medication exposure. So the patch and gum are nicotine, and we know there can be some impact of nicotine. That's what's in tobacco, right? That's part of it is the nicotine. So ideally, we would not use a patch or gum during pregnancy, ideally. But in people who have tried other things and it wasn't successful, there's a place to use them. Yes.
Okay.
But ideally, this is one of those things you want to name. So if you want to be pregnant, you're a smoker, this is something you would want to stop in that preconceptual period and work on doing the patch, the nicotine patch, the gum, and all those things.
Okay. Is there a Black Dr. Spock book for pregnancy? A Black author?
No, I would love to write that book though. It
Oh, I was
like
going to say, that sounds like something you need to be working on.
That's a book I could write that book.
All right.
I love that.
Last question from the speed round. Other than convenience, do you have any idea why retailers reserve parking spaces for pregnant women or those with young children? Is it related to disability of a sort? They can't walk. Let me answer that.
Yeah, pregnancy is not a disability.
In 9 months.
But it does get uncomfortable. Yes, it does get uncomfortable. So I think that's a reasonable ask for pregnant ladies to have
accommodation.
Yes.
Yes.
Right.
Come on now.
It's all love. It's all love. I'm sure the question came from love.
Oh no, it's all love. It's all love. And the answer came from me for love. You know, I like to have fun. I like to have fun. One last thing before Dr. Mel wraps it up. Also, can you take collagen while pregnant?
You should not take collagen during pregnancy. No, we don't have any studies to show what that does. You have a lot of things pass through the placenta. there are different forms of collagen, that type of thing. So the answer would be no.
All righty.
Good question. And I think in general, any supplement or anything that you're taking or thinking about taking, you should run it by your doctor if you're pregnant and lactating, right? Because it also comes through in breast milk before you decide to try something, right? That you might have seen at the health food store or on social media. So really important. All great questions. Thank you so much, Dr. Neale. I told everybody you were going to be dropping the knowledge, and you did. Looking for the Dr. Spock book coming up soon. So thank you so much for being here. Of course, thank you, Lala and Wayne, and all the Be Health Empowered family. Great questions. We're going to see you back soon. Until then, be wise, be well, and be health empowered.
Thank you. Good night.